Hello, my name is Dr. Manuel Torres, and I'm a pediatric surgeon at the Children's National Medical Center in Washington, D.C. Thank you for the opportunity to participate in today's International Medical Conference on Pediatric Gastroenterology and Hepatology. My topic today is on cholelithiasis and cholecystitis in pediatrics. Gallstone disease has long been recognized as an adult problem, but it is quickly being recognized as a pediatric problem because of the significant increase in non-hemolytic cases over the last 10 to 20 years. I have no disclosures. The aims of this presentation are to review the pathophysiology of gallstone disease, discuss broad spectrum of gallstone disease, ranging from asymptomatic to life-threatening, and review diagnostic and treatment strategies. Gallstones are formed from precipitated bile components. Based on their composition, gallstones are classified into most commonly seen cholesterol stones and pigment stones. The three main reasons for cholesterol stone formation are imbalance of cholesterol and bile salt, poor gallbladder emptying, and cholesterol crystallization. Pigment stones are mainly observed in hemolytic diseases, and their incidence remains stable. The hemolytic risk factors will not be discussed in great detail today. However, in sickle cell disease, the frequency of gallstones in children is almost double that of the general population. Pigmented gallstones occur in approximately 50% of children with sickle cell disease by the age of 22, and approximately 20 to 40% of all pediatric gallstone disease can be attributed to hemolytic diseases. The non-hemolytic pathogenesis of gallstones in children is not fully understood, but genetic and environmental factors like the ones listed here are contributing to the rise. The prevalence of gallstones in the pediatric population is increasing and ranges from 1.9 to 4%. Factors affecting the increase include the increased use of ultrasound, and in addition, the increasing incidence parallels the rise in obesity in children. In adults, gallbladder disease affects as many as 25 million Americans, resulting in over 500,000 cholecystectomies per year. Although pediatric gallstone disease is much rarer with 1.3 pediatric cases per every 1,000 adult cases, pediatric patients undergo 4% of all cholecystectomies. The spectrum of gallstone disease is broad, and we will discuss the most often diagnosed conditions: cholelithiasis, cholecystitis, and biliary dyskinesia. Cholelithiasis is simply the presence of gallstones that form in the gallbladder. Gallstones are formed mainly in the gallbladder, less often in intrahepatic or extrahepatic bile ducts. Cholecystitis results when the gallstone migrates out of the gallbladder and gets lodged into the cystic duct, resulting in buildup in bile, causing distension and inflammation. It's traditionally divided into acute and chronic subtypes. However, in the pediatric population, evidence suggests that the two conditions are closely related. Most gallbladders that are removed for acute cholecystitis show evidence of chronic cholecystitis, supporting the concept that acute cholecystitis may actually be an exacerbation of chronic distension and tissue damage. Biliary dyskinesia is a motility disorder of the gallbladder and sphincter rhabdoide. Patients with this condition present with biliary type pain. However, workup shows no evidence of gallstones. HydaScan is the test used to diagnose this condition. In biliary dyskinesia, the HyDA will show reduced gallbladder ejection fraction, and the patient's biliary pain is replicated with cholecystokinin stimulation. Biliary dyskinesia has become the most common reason for cholecystectomy in many U.S. centers. After removal of the gallbladder, the symptoms resolve, and pathology shows evidence of chronic cholecystitis. Now, besides the common conditions of gallstones disease discussed, if gallstones migrate from the gallbladder into the main biliary ductal system, complications may arise, such as cholelithiasis, cholangitis, and gallstone pancreatitis. Cholelithiasis is the presence of stones within the common bile duct. Gallstones migrate out of the gallbladder past the cystic duct and get lodged in the common bile duct. It is estimated that this occurs anywhere from 1 to 15% of patients with gallstones. And cholelithiasis occurs less often in children, but the risk increases with age. If the gallstone obstructs the common bile duct long enough, then this can cause inflammation to everything behind it, including the bile ducts, the gallbladder, and the liver. This is called acute cholangitis. The obstruction of common bile duct leads to bile stasis and sludge, and is a perfect nidus for bacteria that can ascend from the duodenum. 85% of cholangitis are due to gallstones. If the gallstone migrates down the common bile duct and obstructs the flow of the pancreatic duct here distally, then the blockage of the pancreatic duct may lead to inflammation of the pancreas. This is the most common complication of gallstones in children and occurs in 8% of cases. In pediatrics, it's usually mild and resolves spontaneously with the passage of the stone. So how do patients present with gallstone disease? Most patients with gallstones are asymptomatic. 80% of adults with gallstones are asymptomatic, and although the majority of adults with gallstones are asymptomatic, retrospective studies have found that only a third of children with gallstones are asymptomatic. This means that most of the children with gallstones are symptomatic, with the primary symptom being right upper quadrant pain. In gallstone disease, the signs and symptoms that occur depend on where the gallstones migrate through the biliary tree. In cholelithiasis, as mentioned, the majority are asymptomatic. The symptom that occurs with cholelithiasis is called biliary colic. And this is a sporadic intermittent pain triggered sometimes by eating a fatty meal. Normally, the gallbladder contracts to release the bile to help digest fats. You can imagine that the gallbladder in cholelithiasis contracts against the stones, eliciting the pain. It is only intermittent because the gallbladder contracts intermittently and only after eating fatty foods. It may also be intermittent because the gallstone may intermittently be migrating in and out of the cystic duct. Whereas in cholecystitis, that stone becomes lodged in the cystic duct. Again, the most important symptom here is pain. Pain may be more localized, and as opposed to cholelithiasis, the pain is more severe and it's constant and may last greater than 6 hours. A clinical sign can be performed called the Murphy sign, which is pathognomonic for cholecystitis. Other associated symptoms include nausea and vomiting due to the pain, low-grade fever and chills due to the inflammation. In the condition of cholelithiasis, the stone migrates into the common bile duct and gets stuck. This prevents the liver from releasing bilirubin into the intestine, and bilirubin builds up in your blood, resulting in hyperbilirubinemia and jaundice. Since bilirubin does not enter the intestine, stools may become clay-colored. Since there is hyperbilirubinemia, the kidneys filter that blood, and bilirubin gets excreted into urine, making it tea-colored. You may also get pruritus due to the retention of bile salts irritating the peripheral nerves, causing itching. In cholangitis, an acute infection develops because of the blockage of the common bile duct. Because of the infection, patients can get very sick and present with Charcot's triad, which similarly to cholelithiasis, you get right upper quadrant pain, but it is more severe, and you also develop jaundice. But it's the fever that distinguishes this diagnosis, and the fever is not low grade like in cholecystitis. If obstruction is not relieved, the infection can lead to sepsis, and the patient may present with Reynolds pentad, which, in addition to the Charcot's triad, include altered mental status and hypotension. In gallstone pancreatitis, patients present with epigastric pain, right upper quadrant pain, and may have pain radiating to the back. Associated symptoms may have nausea, vomiting, fever, chills, and jaundice. Symptoms may be mild in pediatrics and spontaneously resolve with a catheter stone. The workup of gallstones in pediatric patients is similar to that in adults. The goal is to demonstrate evidence of biliary tract disease. Lab tests should include a CBC, LFTs including bilirubin, amylase, and a urinalysis. All lab results in simple cholelithiasis should be within reference range. Elevated bilirubin and elevated LFTs may suggest that the stone is obstructed in the common bile duct. Elevated white count may suggest inflammation or infection. In terms of imaging, right upper quadrant ultrasound is the study of choice in patients with suspected gallstones. Ultrasound is reliable in detecting gallstones and is more than 95% accurate. Results are immediate, and ultrasound is very accessible. Ultrasound findings in acute cholecystitis include a discrete echo density with acoustic shadowing representing gallstones. Ultrasound may also reveal gallbladder sludge, gallbladder wall thickening, and pericholecystic fluid. It may also reveal ductal anomalies or ductal stones and dilation. Plain X-ray is often obtained but rarely useful. But radiopaque gallstones containing calcifications may be observed in the gallbladder and are more common in the pediatric population. Abdominal X-ray may be beneficial in identifying small bowel obstruction, ileus, or free air under the diaphragm. The most accurate tool in the diagnosis of acute cholecystitis is the HIDA scan. This procedure involves the IV injection of substances labeled with technetium-99, which is taken up in the liver and normally excreted into the biliary system, including the gallbladder. In acute cholecystitis, normal hepatic uptake without gallbladder filling is diagnostic of acute cholecystitis. This test, however, may be unnecessary because the diagnosis can be obtained clinically and the presence of gallstones or sludge can be seen on ultrasound. Ultrasound has proven its usefulness in depicting gallstones. It does not rely on contrast and therefore may be safer. In addition to assessing gallbladder filling, bile excretion can be assessed in response to cholecystokinin, and this is helpful in diagnosing biliary dyskinesia as discussed. In children with suspected biliary complications, MRCP or ERCP can help delineate the ductal anatomy and identify the presence of ductal stones. MRCP may be more sensitive than ultrasonography in detecting inflammation within and around the gallbladder and the biliary tree. Although frequently used in the past, CT scanning is not generally recommended in pediatric patients because of the associated extensive radiation exposure. ERCP is both diagnostic and therapeutic. However, ERCP is usually reserved after identification of common duct stones by either ultrasound or by MRCP. ERCP provides a therapeutic mode of removing a stone or decompressing the biliary tract because it may be used for stent placement, retrieval of stones, or sphincterotomy to allow the passage of gallstones. Now we move on to treatment. Expectant management with periodic clinical and ultrasound surveillance is appropriate in kids with asymptomatic cholelithiasis. In symptomatic patients who are not candidates for surgery or who are refusing surgery, medical management is possible with pain control and diet modifications. Ursodeoxycholic acid therapy in a pediatric study demonstrated resolution of symptoms in 84% of patients. However, complete disappearance of gallstones was only observed in 7% of patients. And significantly, the gallstones recurred in 50% of these patients. Extracorporeal shockwave lithotripsy is also an option. However, all these options have high incidence of recurrence. These patients will have multiple stones and are at high risk of recurrence of symptoms. Intervention with cholecystostomy or ERCP may be indicated. As for the surgical management, laparoscopic cholecystectomy is the standard of care in symptomatic gallstone disease. It has been proven to be safe and effective in children with a low rate of postoperative complications. In conclusion, the surgical treatment strategy can be summarized in the following way. For symptomatic cholelithiasis, an elective lap chole is recommended. As already discussed before, an elective lap chole is recommended for biliary dyskinesia as well. And although lap chole is not recommended for asymptomatic cholelithiasis, in asymptomatic sickle cell patients, an elective lap chole is recommended. For cholecystitis, early laparoscopic cholecystectomy is recommended within 1 week from admission and within 10 days from symptom onset. If an early lap chole cannot be performed, delayed lap chole should be performed after 6 weeks from first clinical presentation. In complicated biliary disease, the gold standard therapeutic procedure is ERCP, with stone retrieval plus or minus sphincterotomy and stenting. This is then followed by delayed lap chole to allow inflammation to subside, except for in gallstone pancreatitis. After ERCP or spontaneous passage of stone, gallstone pancreatitis recurs 25 to 76% of the time. This is associated with the mortality rate of 10% and a major morbidity rate of up to 40%. So a lap chole should be performed as soon as possible. If you delay cholecystectomy more than 6 weeks, recurrence approaches 60%. Thank you again, once again, for this opportunity. It was my pleasure.